the report.
Hi, everyone.
Greg.
I don't know what was going on. I was waiting to get in for like 10 minutes. Did you guys have that problem too?
Yes. I think we seem to be missing our MC.
Can you see my screen? Yeah, Peter had said that he wasn't going to make it.
Yes, yes. We can see that.
Great. So he asked if I would introduce myself. I don't know if we need to give people a few minutes to get in, or I think probably everybody was queued up. All right, I guess I'll go ahead and start then. I'm Greg Fishbein from the University of California, Los Angeles, and it's my pleasure to present this journal club today. I'm going to present this paper. I see Dr. Sampson is on, so I'm pleased to see that. This was in our journal, Cardiovascular Pathology, Cardiac Genetic Test Yields and Genotype-Phenotype Correlations from Large Cohort Investigated by Medical Examiner's Office. And the first author is Sarah Saxton here. And just a brief background, American Heart Association in 2023 reported that the underlying cause of death was listed as cardiomyopathy or cardiac arrhythmia for over 20,000 and 19,000 deaths annually, respectively. Postmortem genetic testing, as we know, is crucial for determining the cause of death in these cases and also for informing families of potential risks. Underutilization of postmortem genetic testing on a national scale creates a public health inequity and fails to prevent familial deaths. And there are a few studies that correlate genetic findings with autopsy results in large, diverse populations. The New York City Office of Chief Medical Examiner investigates roughly 8,500 deaths annually and has over 20 years experience with postmortem genetic testing via their own CAP-accredited molecular diagnostic laboratory. And I want to just point out that this study builds upon a previous cohort of 296 decedents that was published in 2017. So the objectives are to report the yield of cardiomyopathy and cardiac arrhythmia genetic testing in a large cohort, to correlate the genetic findings with autopsy-confirmed phenotypes, and to provide insights for improved postmortem investigations and clinical care. The study population comprised 1,107 decedents investigated by the New York City Office of Chief Medical Examiner between the years 2015 and 2022. Genetic testing was done via a cardiomyopathy and cardiac arrhythmia gene panel. I'll talk more about that in a minute. Variant classification was done using the ACMG AMP guidelines, and data analysis was the correlation of the pathogenic and likely pathogenic variants with the cardiac pathology. So more on the study population. So who comprises this cohort? The New York City Medical Examiner investigates a death when an individual was in apparent health or it occurs from criminal violence, accidents, suicides, or any unusual or suspicious manner within New York City. And as I mentioned before, approximately 8,500 deaths per year. This review of over 1,000 cases between October 2015 and 2022 was basically routine cardiac. So these were routine cardiac focused multi-gene panels that were performed at the discretion of the ME. So not on every case. Which cases got the panel? It would depend on the circumstances of death, the autopsy findings or lack thereof, negative autopsy, the toxicological and microbiological test results, medical family history, and to rule out any genetic etiology of cardiac death. So using these factors, the medical examiner would decide whether or not it was appropriate to perform the test. The primary autopsy findings were extracted from autopsy reports and were categorized as cardiomyopathy, cardiovascular other, so this includes hypertensive cardiovascular disease, atherosclerotic disease, congenital disease, and valvular disease. Non-cardiovascular, so substance alcohol complication, pneumonia, asthma, morbid obesity, gastroenteritis, infection, hyperthyroidism are under this category. And then the last category is a negative autopsy. A couple more details about the autopsy findings. There's the definition of cardiac hypertrophy was based on not just gross heart measurements, but also microscopic evidence would count as hypertrophy. And the myocarditis was defined as an infiltration of lymphocytes into the myocardium, sometimes associated with myocyte necrosis. And I think this would depend on antemortem viral symptoms, perhaps when available, and the office does not do viral testing routinely. When the findings overlapped, the most prominent phenotype contributing to death was selected to avoid duplicate counting. And infants, so 1 year old and younger, were analyzed separately from the older age decedents due to unique extrinsic, such as unsafe sleep, and intrinsic, such as immaturity risk factors. The DNA was extracted from dry bloodstain cards or from tissue and RNA later. Sure Select XQT target enrichment workflow and pair-end sequencing were completed on NextSeq 500 DNA sequencer. The data, the NGS data, were analyzed using this I don't know if it's NextGen or NextGene software, and Genetics Assistant with, this is the reference genome. And the Sanger sequencing was used to confirm reportable variants with low confidence. So I'm not going to show the supplemental table with the 132 genes. It makes for a pretty bad slide. But I will say cardiomyopathy and arrhythmia genes were included in the panel based on literature reviews and ClinGen's classification of evidence supporting a gene's role. Genes not classified by ClinGen as having definitive or strong evidence for their role for a given disease were carefully considered based on literature review. And for a gene whose role in disease has not been well established, non-benign variants were classified as variants of uncertain significance. Another thing to mention, 44 of the genes, including filament C, were added to the panel in 2019. So this is in the middle of the study. 715 of the 1,107 cases were analyzed for the full panel, and the rest didn't have these 44 genes. Variants were independently classified by a board-certified clinical molecular geneticist, a genetic scientist, and a board-certified genetic counselor using guideline standards into the 1 of 5 categories. So I think we're familiar with these: pathogenic, likely pathogenic, variant of uncertain significance, or VUS, likely benign, and benign. The variants were evaluated based on literature review, clinical database search, estimates of minor allele frequency from large population databases, in silico predictions, and also by applying a published statistical framework that assesses whether a variant is, for example, too common to cause disease. Specific genes with well-established disease mechanisms were classified based on variant type. So truncating variants leading to haploinsufficiency in genes like myosin binding protein C3 and filament C were classified as pathogenic or likely pathogenic, and missense variants in these genes were classified as VUS or benign. In contrast, missense variants in critical functional domains in genes like myosin heavy chain 7 and MYH6 were classified as pathogenic or likely pathogenic. Truncating variants in those genes were largely classified as VUS or benign. And TTN, Titan missense variants that are considered not clinically significant. So interpretation of truncating Titan variants depended on whether the variant was in an exon constitutively expressed in the heart and in a functional domain. Descriptive statistics for categorical variables were presented as the number of cases and percentages, chi-square with Yates correction, and Fisher exact test to compare discrete groups, and p-values were two-sided. Values of less than 0.05 were considered statistically significant. All right, so I will move on to the cohort characteristics. So here is table 1 showing the 1,107 the cases. You can see that as far as age goes, most of them sit in this range here of the 20 to 50. There are considerably more males than females, and the ethnicity, it's very diverse, but mostly Blacks, Hispanics, and whites. Here's how the cohort broke down. The ones that were greater than 1 year old were classified as cardio. So I guess most of them were cardiovascular, or a third of them were cardiovascular other, followed by negative, followed by cardiomyopathy, followed by a non-cardiovascular cause of death. In the infants, which represents 12.9%, shockingly, to me at least, 49% were characterized as unsafe sleeping, which is a really high number. And then you can see here that less than 8% were negative. Taking a little bit more of a deep dive into that, you can see that under cardiomyopathy, the most common cardiomyopathy was dilated cardiomyopathy, followed by hypertrophic cardiomyopathy, followed by arrhythmogenic cardiomyopathy. So the big three right there. And then a number of cases were described as just having cardiac hypertrophy or myocardial fibrosis. The most common of the cardiovascular other was hypertensive disease, followed by myocarditis, followed by atherosclerotic disease. I thought that was an interesting order. And here's a list of the non-cardiovascular diseases. With regard to infants, this was in supplemental table 2. As I mentioned, a shockingly high number, 49% were characterized as unsafe sleeping. The next most common being viral syndrome, followed by negative. I've pointed out here where the cardiovascular diseases come in. We have myocarditis, 3 cases, dilated cardiomyopathy by itself, 1 case, dilated cardiomyopathy with endocardial fibroelastosis, 1 case, 1 case with hypertrophy, and 1 histiocytoid cardiomyopathy. So in summary, it's diverse demographics, ages ranging from 1 day to 74 years with varied ethnicities. The primary autopsy findings in patients or decedents over 1 year old were cardiovascular other, followed by negative autopsy, followed by cardiomyopathy, followed by non-cardiovascular causes. And the primary autopsy findings in the infants was unsafe sleep conditions, followed by other factors, followed by negative. So now I will move on to the molecular test results. So here is figure 1, and you can see that for the cardiomyopathies, the red is the pathogenic or likely pathogenic variants. You can see that 26.1% of the cardiomyopathies were classified as such, the rest being either VUS or benign. And this was a pretty high yield compared to the other categories and statistically different. You can see that the next highest is 4.3, and in the negative cases, only 2.7% had pathogenic or likely pathogenic variants. And very interestingly, that's even higher than the infants. And then just by age group, you can see here that the infant rate's very low, but the rate of pathogenic or likely pathogenic variants in all of these different age groups is relatively similar. And you can see that the only one that there's any statistically different group is basically this 51 to 60 has a higher rate, but otherwise pretty consistently the same. By gender, you can see that there's not a significant difference between the amount of pathogenic or likely pathogenic variants found in males and females. The one interesting thing, though, is that as far as the individual variants that were involved, myosin binding protein C3 variants were more commonly found in men than women. This is the pathogenic and likely pathogenic. Otherwise, there was no statistically significant difference between men and women. Under the pathogenic and likely pathogenic category, you have 73 that were part of the cardiomyopathy gene panel and 14 that were of the cardiac arrhythmia gene panel. Of these, the most common were associated with hypertrophic cardiomyopathy, followed by dilated cardiomyopathy, followed by arrhythmogenic cardiomyopathy, and lastly, Noonan syndrome. And with regard to the arrhythmias, 12 of them were in the Brugada long QT groups, and 2 were CPVT genes. So you can see here that the MYBPC3 was the most common pathogenic, likely pathogenic variant, which is being assigned the hypertrophic cardiomyopathy category. And then here's where the SCN5A that is associated with Brugada syndrome and long QT3 would be the highest, the most common one found in the arrhythmia panel. So for the pathogenic and likely pathogenic variants that were detected, there were 87 cases, 73 were in cardiomyopathy genes, and 14 were in arrhythmia genes. And of the 73, all of them essentially the genotype and phenotype correlated except for 2. We'll look at that. And all of the cardiac arrhythmia genes essentially correlated. VUSs were detected in 437 cases, and likely benign variants were found in 583. So in terms of the diagnostic yield, hypertrophic cardiomyopathy had the highest yield, meaning that if the pathologic diagnosis was hypertrophic cardiomyopathy, a pathogenic or likely pathogenic variant would be detected 54% of cases, followed by arrhythmogenic cardiomyopathy, which makes sense to me, given that these are what we know about the diseases. I think it's clearly interesting that myocardial fibrosis alone had a yield of 20%, and dilated cardiomyopathy, which we know is a phenotype with diverse number of causes, was also around 20%. Interestingly, myocarditis had a rate of 11%, which is surprising to me, and cardiac hypertrophy alone, 10%. So this is just a breakdown of the pathogenic or likely pathogenic VUS and benign for each of these diseases. You can see we've already talked about the pathogenic or likely pathogenic, but this just provides some information about how often what VUSs were found and likely benign or benign. And here, this is just showing that the diagnostic yield in hypertrophic cardiomyopathy, arrhythmogenic cardiomyopathy, fibrosis, dilated cardiomyopathy, myocarditis, and cardiac hypertrophy were significantly higher than those with a negative autopsy. So I think I might have skipped a point here. Okay. In summary, the diagnostic yield for pathogenic or likely pathogenic variants were significantly higher in decedents with cardiomyopathy compared to those without, and in non-infants compared to infants. The diagnostic yield by cardiac autopsy finding was 54% in hypertrophic cardiomyopathy, 47.1% in arrhythmogenic cardiomyopathy, 20% at myocardial fibrosis, 19% in dilated cardiomyopathy, and 11% in myocarditis. So looking at the genotype-phenotype correlation, here's the table of all of the pathogenic and likely pathogenic variants in cardiomyopathy genes. So what I've done is I've picked out the 2 that didn't correlate to bring up, to just focus on these. And here you have a case with myocarditis as a finding, and the cause of death, myocarditis, likely viral, that had a filament C mutation, but there was no evidence of structural heart disease. So this was labeled as no correlation. Of course, this is a 23-year-old, and this is a dilated cardiomyopathy associated with filament C mutations, generally presents later in life. So it could be that this was just a patient who got myocarditis and hadn't developed the phenotype yet. Similarly, we have here a 17-month-old male who had neuropathy feature suggestive of cerebral and hippocampal dysgenesis, who was found to have a likely pathogenic mutation in desmoplakin. So this was assigned the no correlation category, but similarly, I would expect that at this age you would not have the DSP phenotype. In terms of the arrhythmia genes, you can see that they essentially always correlate, because if you have a negative autopsy, that's the phenotype you expect, a sudden cardiac death from an arrhythmia. And as I mentioned before, certain cases of myocarditis also had a mutation in a pathogenic or likely pathogenic variant in the genes. As you can see here, and people can die of other causes. You'll see there's cases where there's structural heart disease, like dilated cardiomyopathy, but we know that these can be associated with this genotype, and so this is not inconsistent. So to summarize, there was a strong correlation this is for the cardiomyopathy associated genes. There's a strong correlation between the genetic findings and the cardiac pathology. Most of the pathogenic and likely pathogenic variants were in hypertrophic cardiomyopathy cases, primarily in sarcomeric and protein kinase genes. Myocardial fibrosis observed in 5 cases with pathogenic or likely pathogenic variants found in variants found in DCM, HCM, and ACM genes. And cardiac hypertrophy was predominantly observed in the patients with variants in the hypertrophic cardiomyopathy genes. I thought it was very interesting that only 1 out of the 5 peripartum cardiomyopathies had a pathogenic or likely pathogenic variant, and it was in Titan. And the 2 that did not have a genotype-phenotype correlation, as I mentioned, were a 23-year-old with myocarditis, no cardiomyopathy pathology, and filament C likely pathogenic variant, and then a 17-month-old with no cardiac findings in a DSP variant. But both of these were younger than their diseases typically manifest. So I think that this could just be true and unrelated. The arrhythmia-associated variants, 35.7% had a prior arrhythmia history. Of course, I think in this setting, there's not always a complete history. 50% had cardiovascular findings at autopsy, and all of the 3 cases with no history or autopsy findings had variants in SCN5 alpha. Of the myocarditis cases, variants were found in ACM genes, PKP2, DCM, and arrhythmia-associated genes. They report that focal myocarditis was more common in the younger decedents, whereas extensive changes were observed in the older decedents, and no clear correlation between the location or pattern of the myocardial fibrosis and the genotype was identified. But I think the information regarding the location of fibrosis was limited. 10 novel pathogenic or likely pathogenic variants were identified, 8 in cardiomyopathy genes, all loss of function variants. Here they are here, and 2 in cardiac arrhythmia genes. 117 novel VUSs were identified. Those are listed in a table I'm not going to show. And 3 recurrent variants in myosin binding protein C3, plakophilin 2, and TNNI3 were present in unrelated decedents. 1 Titan variant was seen in 2, so recurrent variant was seen in 2 biological brothers that died 10 years apart. So for the discussion, basically what we found was postmortem genetic testing had higher yield in decedents with cardiomyopathy. These are the numbers that I mentioned before, which is comparable to the previous studies that are cited here. The greatest number of pathogenic or likely pathogenic variants were in myosin binding protein C3 for hypertrophic cardiomyopathy, Titan for dilated cardiomyopathy, and PKP2 for arrhythmogenic cardiomyopathy, which is also comparable to previous studies. 20 and 9.6% with myocardial fibrosis and or hypertrophy had pathogenic or likely pathogenic variants in genes associated with the big 3 cardiomyopathies. which may indicate some alternative phenotype for these variants. And of course, we did see in this a diverse phenotypes of cardiomyopathy genes. So for example, DSP wasn't simply associated with arrhythmogenic cardiomyopathy. There were cases where the phenotype was dilated cardiomyopathy or just fibrosis or just hypertrophy. And another example is the filament C, where dilated cardiomyopathy, fibrosis, and hypertrophy alone were identified. Very interestingly, variants were found in 11% of decedents with myocarditis versus 2.7 in negative autopsies. And I think this supports evidence that these patients with cardiomyopathy or channelopathy mutations are probably just at higher risk of developing severe complications from myocarditis. With regard to age, it seemed that the utility of genetic testing was similar across all age groups except for the infants. And it challenges the notion that genetic testing be reserved for decedents under 40. I think that's part of I think what motivates that is cost, but the yield is high above 40 as well. 22 decedents older than 40 had pathogenic or likely pathogenic variants. All had cardiac pathology or a history of arrhythmias. But not testing is a lost opportunity for familial preventative care. Clearly, there's a family impact for doing the testing. This can enable cascade family screening and preventative care. And the paper argues that a negative result is still valuable because it may prompt further investigation, such as more extensive genetic testing, including genes targeting epilepsy, and perhaps in the future whole genome sequencing. Some limitations, I think the selection bias is a big one, the bias against, it was one thing that occurred to me is if there's a lot of people, for example, walking around on cocaine, so not everybody who has cocaine in their system dies, and like the myocarditis, I don't know if the medical examiner would find a positive toxicological result and exclude genetic testing. Same for infection and other circumstances. And of course, there's a bias toward testing clearer cardiac phenotypes. So many of the negative phenotypes were not tested. So those are a couple things. And then the retrospective design, right? So there's variations in the testing protocol over time that we saw, those extra genes being added halfway through. And then, of course, the individual practices of pathologists in terms of what's considered significant fibrosis, et cetera, and variant interpretation from the geneticists. There was limited pathological data that could be extracted from the reports, such as the location and subtype of fibrosis, severity of myocarditis, and there's limited clinical data as well. So the incomplete family medical histories to correlate with novel variants and VUSs was not always there. So just generally, the postmortem genetic testing is essential for a comprehensive death investigation. We found that it has a high diagnostic yield, particularly when the findings are cardiomyopathy, myocardial fibrosis, or myocarditis. And of course, the benefits, the accurate cause of death determination is one benefit, and family screening and prevention is another. So with that, I will open it up to questions and discussion. Barbara, I don't know if you want to make any comments, if there's something.
Your presentation was great, Greg. I think I understand the paper even better now, so thank you. Another interesting thing, as far as looking at the, the usefulness of doing this kind of testing is also some of the VUSs that, must be classified as VUSs are really very compelling. As being much more important in the cause of death. So we also get a lot of information that we do share with families, through our genetic counselor, and making sure that they get the follow-up that they deserve. So it's, even though the percentage may seem really small, obviously it's important that the pathogenic ones are, super important, but I think there's a lot of information gained from the VUSs as well.
I have a question and a comment. First of all, Greg, really nice job presenting that paper. Barbara, very nice work. there have been several papers in the last few years that have talked about finding mutations in myocarditis, finding genetic mutations, and people saying that that is increased in myocarditis. Maybe it makes people more susceptible when they have a viral infection to die of it. It seems plausible to me. So that part was interesting, that relationship. Secondly, now that there are these new criteria, these large specimen myocarditis criteria that we're working through that talk about myocyte injury, and maybe it's more of a question for Barbara, do you have a sense of those myocarditis cases that you had, if they actually had myocyte injury there?
Yeah.
Or
Yeah, to my knowledge, they all had myocyte injury with them if the cause of death was thought to be myocarditis. We can't help a stray medical examiner from calling something myocarditis, but not listing it then as the cause of death. So I think all of them had myocyte injury, and actually Amy Kantorovich, who I think is the second or third author on this paper from Mount Sinai, is very interested in exactly the relationship that you described between myocarditis and these channelopathy variants in particular. So we've been looking very carefully at those cases, and I think there is definitely a connection there.
Barbara,
Right.
do you think that there were cases where, because of the finding of myocarditis, testing was not done?
In the early cases, yes. I mean, the earlier time period, but since our collaboration with Dr. Kontorovich, we've been testing everybody who has myocarditis for this, looking for, these kinds of changes. So it's probably not uniform throughout the time course, unfortunately.
What about the toxicology? Because I think this raises also the question of whether, like myocarditis, people who are using drugs more casually are going to be more susceptible to sudden death.
Absolutely, and they should be. So if you had cocaine plus something else, that it's just logical that it is a worse scenario. Unfortunately, we don't have the resources to test everyone who has a positive, say, cocaine, or pick your favorite drug that you think might be related. But the case. That being said, there are cases that kind of sneak in for other reasons that do have positive toxicology. So there is some data there, but I think, if we had unlimited resources, doing that in a more formal way, I think would be very informative.
Right.
We have definitely had anecdotal cases of people with SCN5A mutations and cocaine.
Now, I mean, forgive me for not knowing how it works, but when you do toxicological studies, are you presented with a quantitative result early or only later?
No, well, the toxicology, we can do what's called a quick tox, like they do in the ER at the autopsy table to guide our decision. So if you have a young person who's quick tox positive, then you might not say, and nothing else at autopsy, you might not send the genetics. But if it's negative, then you would. So
But is that quantitative? Sorry.
But that test is not quantitative, but the final toxicology is always quantitative. So when and tox is sent on almost every case throughout the agency. So eventually we'll have a quantitative result for almost every disease.
Okay. And do you ever say this is below threshold, that it probably is not really the cause of death?
It depends on the drug, right? So drugs like cocaine in any amount, we know, apparent cocaine, not breakdown products like benzoylecgonine, but apparent cocaine is dangerous at any level. Opioids, we would look more carefully if the person is also on a methadone program, has a long history. So there's some drugs that the interpretation of the levels is more important than in others.
The fascinating study, and I think it's when everybody wonders what you're going to find by doing this, so I think it's really satisfying to see some numbers on paper. So thank you very much for the work.
Of course, no, it's a tremendous effort by the lab to pull this all together. It was not easy.
So I did prepare, because I remember last time I did this, I had a lot of time left over. I did also prepare this paper, same group, studying molecular genetic characterization of sudden death due to thoracic aortic dissection or rupture. If we have other comments, I mean, we can talk about now, or I can present this and we can speak more at the end. Maybe I'll go ahead.
Sorry, Greg, again, very, very well presented. The myocarditis genes correlate with dilated cardiomyopathy or can correlate with hypertrophic and arrhythmogenic cardiomyopathy also?
Well, I didn't present the full list in the cardiomyopathies, but I do have I have actually a spreadsheet here. But you can see that there were myocarditis cases with some of the arrhythmia associated genes, SCN5A. This is all of these. So then also the QCNQ1 and let's see. I think I put together. It doesn't have this cause of death here. Okay. So I'd have to look through the long list to tell you about the cardiomyopathies, how many myocarditis cases, but Barbara, maybe you know.
Not off the top of my head, no.
Very good, thank you, thank you.
It's a long list, but it's there. So you could actually go and the supplemental tables were really good, helpful too. I went through a lot of that. You know, if you have specific curiosities, you know, about how often you find myocarditis and with certain genes, I think all that information should be available to you. I think the VUS list was not as comprehensive. It didn't have the diagnoses. I couldn't find that. But certainly for the pathogenic and likely pathogenic, all the information is there. So you can just go online and get it. Okay, so I can talk about this study now.
Something, sorry.
Oh, yeah.
Yeah, it's very interesting. Congratulations, Barbara group. We have a different approach in many European countries because we cannot perform full genetic testing according to legal aspects, but sometimes we can do it. My question is, do you include the full interpretation of genetic results in the autopsy reports, and how much does it cost, this genetic testing with interpretation of results in daily practice?
So the lab is part of the medical examiner's office. They have a huge DNA lab, mostly for criminal cases, and this is a part of that. So the cost is absorbed by the city of New York. And it's, you know, the price for us also is coming down tremendously. So I don't know the exact, but it's a few $100s per case, something like that.
So,
and your other question was what?
No, because we have sometimes cases when we introduce genetic testing in our practice, in our autopsy reports, it's 4,000 euro per case.
Wow. No, definitely less expensive here.
Yeah, yeah. And evidently we cannot do for each case. So but it's a really interesting.
One of the wonderful things about, I mean, when we started this 20 years ago, we were the only ones doing it. And now it is much more common throughout the United States for MEs and hospitals also to do this kind of testing, which is available, you know, for a relatively reasonable cost. I'm not going to say it's cheap, but
I think at least in our experience, the question was also how should we really transmitted the results to the family.
Oh, right. So yeah, the results are completely transmitted to the family via our genetic counselor. We have a full-time genetic counselor who does all of that and makes sure that the families, where necessary, are connected with clinicians to follow up with them. And also, actually, we're very excited that we just are in the process of getting funding for doing actual testing for the relevant mutations in living family members, so that family members will have that information then when they go and to seek clinical care. Because we were finding a lot of people were just lost to follow-up. So the city agreed with us that this was a very important thing to offer to families.
Yeah, but I think that you are in a perfect place, New York. It's really, you are very happy to have everything. But do you think that it's the similar context, the similar possibilities, facilities you can find for each medical examiner?
Right. It like I said, 20 years ago, nobody else was doing it. And now I'm seeing autopsy reports from all over the country more and more with genetic testing results. And if you go to the big meetings here, there is a lot of interest, and medical examiners definitely see the utility in this. And now that the price has come down, it's a little bit more feasible for them to do it. So I'm very optimistic that this is going to become more and more part of the routine workup, at least in the cases where there's no autopsy findings to explain the death.
Here in Europe, we are a little bit blocked by this ethical approach of the right not to know. It means we have first to provide the genetic counseling, and if it's something, they have right not to know. So this is a little bit different, I know.
Yeah, I mean, here the city at least has found that it's from a public health point of view, critical in determination for the cause and manner of death. If the family, we can tell the that the family doesn't have to speak with us if they don't wish to know, but it is available to them, right?
Thank you very much.
Yeah, I'm sure that's part of the conversation with the genetic counselor. But the other thing I just wanted to add is I don't think you need to have your own dedicated genetic counselors with telemedicine. You know, I think right now, at least in my institution, you know, we can do outreach to all over the country. You know, if patients have autopsies done at UCLA and get genetic testing, and I think that you probably can centralize that. You know, that they don't have to, doesn't have to be done in house.
Definitely.
Greg, okay, here I am. Just wanted to say that was a really nice summary of an even nicer study. You know, here at Duke, it's been a battle to get them to support genetic studies on the autopsy service. And so this is, you know, really nice to have in our armament when we try and at least squeeze certain cases through. I wonder if you, when you had cases that may have had some hypertrophy and coronary artery disease, did they all get genetic testing as well? If you thought it might be ischemic as a cause, because you know, and here I've seen a lot of our Titan cases, which come as explanted hearts, that even the young patients have accelerated atherosclerotic disease, and I think there was a study out of Geisinger that found that as well. So I was wondering if you did genetic testing even in cases that you thought, well, this looks more like just, you know, our typical ischemic.
Yeah, because obviously we're such a busy office, we have many people whose cause of death is atherosclerotic cardiovascular disease, and we wouldn't have the bandwidth to begin testing, you know, those cases. So if the medical examiners find enough atherosclerosis in their minds to explain death and nothing, you know, outside of the quote unquote ordinary, they would not order testing. So we're missing that group.
Yeah, it might be interesting to see in younger folks, or certainly younger women, if genetic testing would show up, you know, something you know, outside of atherosclerotic genes. But a really nice study, and appreciate it.
Barbara, one other question. With regard to the epilepsy panel, do you have any experience reflexing to epilepsy panel?
Yeah, we have been doing that for the last, maybe 10 years or so. And the results are, you know, pretty similar, you know, for people, I would say the positive, you know, for likely pathogenic is probably, you know, 5 to 10% of the cases that we test. You know, we try to limit it to people who really have true epilepsy, not a, you know, a final event that appears to be a seizure. But it, you know, we're limited by, you know, what is sent to us, of course.
Do you have any experience with the PNES?
What the PNES and what are
Psychogenic non-epileptic seizures?
I don't believe so. Not that I don't focus as much on the epilepsy. Rebecca Folkerth, who many of you know, was running that part of it. I don't know about that.
I mean, I had a case that was diagnosed in life. Finally, we had another cause of death, so we didn't have to, because there are some papers that claim that can have the same or be close to the same incidence of sudden death as true epilepsy.
Interesting. Any other comments? All right, well, we don't have the tremendous amount of time, but I think I can still get through this. So thoracic aortic dissection and rupture, TADR, I'm going to call it now, accounts for 4 per 100,000 deaths in the US. Up to 25% of these cases are linked to a single gene variant. So of course, genetic testing can identify the underlying cause of death and enable preventative measures for at-risk family members. And the New York City Office of Chief Medical Examiner routinely conducts genetic testing on these TADR cases. So the study objective was to understand the prevalence of TADR and sudden death, evaluate the value of molecular diagnostic testing, and explore the genotype-phenotype correlation in a diverse cohort. This was also a retrospective review of cardiovascular genetic testing cases between 2019 and 2022. 20 genes associated with familial TADR were analyzed using NGS, and the variant interpretation was the same as before. So the number of cases was 1,078. The cases were selected for testing based on cardiovascular autopsy findings, medical history or symptoms suggestive of cardiovascular disease, and sudden unexplained death. And in the TADR cases, the general appearance, head, cardiovascular, lung, and skeletal changes were documented per previously published checklist. So that can be found here. I'll show the genes in the next slide, but this was part of the comprehensive testing. So there were also channelopathies, cardiomyopathies, thrombophilia, and sickle cell disease tests that were performed as well. And the methodology was as I described in the last set of slides. So here's the list of 20 genes. We all recognize the big ones: Ehlers-Danlos, Loeys-Dietz, Marfan, and plus others. So of the 1,078, 34 were TADR cases, 8 of which had a likely pathogenic or pathogenic variant. 4 had VUSs, 22 were negative. And in the cases without TADR, aortopathy, the rate of only 2 had aortopathy variants that were significant. So as I mentioned, in the 34, 23.5% were considered pathogenic or likely pathogenic. VUS was 12 and benign was 65%. Of the aortopathy genes that were with significant variants, fibrillin 1 was the most common. So just an overview of those slides: 1,078 cases underwent testing. 34 had TADR. 8 of those had pathogenic or likely pathogenic variants. 4 had VUSs. Interestingly, only two non-TDR cases had pathogenic variants. They were both in fibrillin 1, and this was unrelated to the cause of death. And no TADR cases had pathogenic or likely pathogenic variants in non-TADR cardiomyopathy arrhythmia genes that we looked at earlier. The genes with the highest prevalence of pathogenic variants were FBN1, TGFBR2, and TGFBR1 and MYLK1 case each. As far as the demographics, you can see I think this figure confused me a little bit, but I think it's describing the indication for genetic testing, what the suspicion was. So here, most of them were done out of suspicion for cardiac disease, like cardiomyopathy or channelopathy. Aortopathy represented only 3%. You can see here that most of the patients were in this 20 to 50 age group, and the same ethnic diversity as the last slides. And here again, more males than females. Here is a distribution by age group, and then sex, and then ethnicity. I think one thing that's interesting here, I just wanted to put the arrows to point out that here's your highest yield category. The 11 to 30-year-olds have the highest number of pathogenic variants, but the prevalence of TADR is still higher in this age group that didn't have as many genetic associations, and that's not unexpected. So yeah, by age group, like I said, the high yield age range is 11 to 30, and variants were less often picked up in these older patients. So the highest prevalence in 41 to 50, 32%, but the highest yield in those under 30. More males than females had pathogenic variants, and this was, as I described, a diverse cohort. So of the variants, this is the list of TADR and non-TADR cases with pathogenic and likely pathogenic and VUSs. So this was the entire table. And then I extracted from there just the pathogenic and likely pathogenic to present. So here you can see in the non-TADR cases, as I mentioned, they were both in fibrillin 1. And then here you can see the distribution here. And what's interesting is the syndromic features. Only one had a antemortem diagnosis of Marfan, but some of them did have features suggestive of a syndrome, but not all. This is a figure that I have to admit I can't appreciate as much as maybe some people, but this is generally just showing you where the distribution of the variants are in the various domains in these genes. So I'll let that sink in. And then as far as variants go, 3 variants were first described by this study. One was a likely pathogenic variant in fibrillin 1, and the other 2 are VUSs. The pathogenic or likely pathogenic variants in fibrillin 1 were mostly truncating variants, whereas in these 2, it was missense or in-frame deletion variants. And as far as genotype-phenotype correlations, there was a younger age at death associated with variants in these genes, and VUSs, or this one likely pathogenic one, was associated with older age. As I mentioned, only one case had an established diagnosis of Marfan antemortem, but this case, apparently they were not able to genetically confirm that due to financial concerns. So this provided that genetic confirmation. Of the molecular negative cases, there were 22 that had negative results. They did not have any additional syndromic features. The majority had non-genetic factors that could contribute to disease, like hypertension, substance use, polycystic kidney disease, but 5 had none. There were 2 molecular negative patients who died at 16 and 21. And the paper indicates that these are still probably likely genetic, just not captured by the panels, and suggests that these further studies may elucidate a genetic basis. And as far as the conclusion, I think the main thing that's interesting is the genetic testing, that the yield was 23.5%. And so this is, in this case, it's all comers, right? All of the sections and ruptures, despite if there were risk factors or not, got tested. So that's very informative. Pathogenic and likely pathogenic mutations in these genes were most likely to be found in the TADR decedents, especially those who died young, whether or not they had syndromic features. And determining the genetic contribution of decedents TADR informs risk management of biologically related family members. Some limitations: the retrospective design limited a lot of the clinical information. The cohort may not represent all TADR deaths in New York City. This is certainly true. I think, I don't do forensic pathology, but I see these patients who come in through the ER. So this definitely is not going to be a comprehensive cohort. And older patients, like I said, like going through the ER would not have been referred to the OCME. The study points out this limitation, that these polycystic kidney disease genes are not included in the panel, but I think makes a very good point that the diagnostic manifestations are usually present at autopsy grossly. So I don't think that's a big limitation. And that's it. So with 5 minutes to spare, do we have any questions or comments about the aortopathy cohort?
I'll just add that some of you may remember the death of Grant Wall at the World Cup in 2022, the reporter who died in Qatar. And he actually had an autopsy at the New York City office. And he also he died of an aortic dissection, and he had a pathogenic mutation. And his wife is a science reporter, and she has done a lot of press surrounding the importance of genetic testing in aortopathies in particular. So she's been a great advocate for, getting the word out that, these are often can have a genetic basis.
I think it's interesting that there were the two cases with the young people without any
Yes.
mutations. I had a case of a 30-year-old who had 2 tours in Afghanistan, who clearly was evaluated by the military and found to be fit, who had a dissection from his carotid to his iliac, and we sent it for a panel and it was negative, and I regret sending it for the panel and not doing more comprehensive testing.
No, there's a lot of those cases that you think they have to be genetic.
Yeah. Well, I guess if there's no other questions or comments, we can adjourn. Thank you very much for your attention, everybody, and thank you, Barbara, for fielding all these questions and for the excellent research.
Thank you, Greg, for great presentation and discussion.
Thank you all.
Bye, everyone.